Welcome back, folks. Hope you had a great lunch. Pleased to introduce our next speakers. This is going to be a fun one, folks. Psychiatrist versus psychologist. Dr. Rakesh Jain and Dr. Sandra Jain. So I'm pleased to introduce both. Rakesh Jain is a clinical professor of psychiatry at the Department of Psychiatry at Texas Tech University School of Medicine in Midland, Texas. He also has a private practice in Austin, Texas. Sandra Jain is an adjunct clinical affiliate at the School of Nursing at the University of Texas at Austin. For you UT fans, that's the other UT, the one with the wrong color. Yep. Dr. Jain is also in private practice where she focuses on wellness and the impact of positive psychology on patient outcomes.
Well, hello, dear colleagues. It's good to be with you. And Sandra and I are looking forward to talking to you about one of the most exciting areas of current contemporary mental health landscape, which is psychedelics. And the question is psychiatry ready for psychedelic therapy? And Sandra and I have been involved in this area for many years now, and we are so excited to offer you a deep examination of the potential advantages and pitfalls of psychedelics. So my name is Rakesh Jain, and I'm a clinical professor of psychiatry at Texas Tech University School of Medicine in Permian Basin in Midland, Texas. And my co-presenter, Sandra Jain, who will introduce herself as soon as I'm finished. And she is a therapist, and she's also an affiliate at the University of Texas at Austin School of Nursing. Our learning objectives are very clear and simple. We want to help define psychedelics. We want to better understand what is the database supporting their utilization in psychiatry. Sure, our society has been using it for decades, possibly for actually much longer than that. But what is the medical reason to do so? And then we look at, if you're thinking about doing integration work in your field, how can you incorporate that? So between Sandra and I, we do plan to offer you a very complete look at psychedelics. But I do think it's important to first establish, is it an emerging science, or is there actually good database to support it being adopted by us? So if you look at what evidence-based medicine currently is, and if you're a prescriber or a non-prescriber, this is important. Well, evidence-based medicine is, what is the evidence, what is the clinical experience, and what do patients prefer? It's that overlap between three that really constitutes evidence-based medicine. So clinical experience, there's a lot. There's so much work that has been done. Patients really like it. I'm certain you have encountered patients who have talked up or are asking questions about psychedelics. But quality research, I was only able to give it a 1+. So what's lagging behind currently is solid replicated clinical study data. Having said that, there's actually more than we had originally anticipated when we started digging into this field. There are, of course, 4 levels of clinical evidence, and the highest level is, of course, randomized controlled trials, RCTs. That is the gold standard, and that requires at least the basics: double-blind, multi-center, randomized, multiple replication studies. If you agree with me that that is the gold standard, at the moment, we only have 3 psychedelics that meet the criteria. Ketamine, yep, that's a psychedelic. It's a medicine and a psychedelic. Mdma, which has been in the news since 1970s. And Psilocybin, which has been with human civilization probably for 5,000 to 6,000 years at the very least. Now, there are lots of psychedelics. Many of them are literally cultural phrases and words: LSD, mescaline, but there are many more: ayahuasca, DMT, and many designer drugs. So we in the field of mental health have a responsibility to understand the positives and negatives of psychedelics, and we will offer you both of that today. So today, we'll start our conversation out by talking about ketamine. So ketamine has multiple potential actions, and psychedelic experience is definitely one of them. Please think of psychedelics, particularly ketamine, as both medicine and a psychedelic intervention. It's possible to be both, as I'll show you the evidence. So there is a direct effect. You will undoubtedly be aware of how ketamine can positively impact neuronal growth. But on top of that, the psychedelic activity can be profoundly helpful, and that is our focus today. So if you look at the middle of this slide, just look at how many different activities ketamine can have. It really is quite impressive. It can work through multiple neurotransmitters. It can work on mTOR signaling. It can work on GSK3. It can also work on BDNF. So one single substance can do all that. Yes, it can. But on top of that, it most certainly can act as a psychedelic. And by the way, the definition of the word psychedelic really is mind manifesting. That's the literal translation of the word psychedelic. And ketamine can absolutely, in many patients, give them a deeper understanding of their subconscious. It can also give them experiences, as Sandra will talk about later, that can be deeply utilized in psychotherapy. I have no doubt, again, that intravenous ketamine therapy is most likely being offered in the city you live and practice in. Is there evidence to support such utility? I know the FDA has given it no formal indications for use in depression, not ketamine anyways. S-ketamine, yes. Ketamine, no. The moment the data is actually very persuasive, this is a study, a meta-analysis from just last year. And what you're able to see is that intravenous ketamine therapy in the vast majority of studies clearly and convincingly shows an antidepressant effect. Clearly and convincingly, even in patients who have often failed antidepressants before. In other words, it has clear effectiveness in treatment-resistant depression. And I'm circling for you, the overall effect size is actually quite impressive, even in these difficult-to-treat patients. Maurizio Fava, along with multiple other colleagues, have actually looked at dose-finding studies. This is actually a very high level of evidence of its effectiveness. When you have placebo in multiple doses, then very often you can establish if there's a true effect. And here what we're seeing in one single day after the administration of ketamine, if it's dosed correctly, and the correct dose appears to be in the 0.5 to 1 milligram per kilogram, it actually is quite effective in one single day. That's not the language psychiatry uses often, right? We're used to talking about weeks or months or years sometimes. Here we're going to be talking about hours and days. So yes, part of this effect may well be mediated through its psychedelic effects. Okay, so most effects are pretty rapid. There's even more innovative thinking happening in the world of ketamine. Here is a 4-day continuous infusion of ketamine in treatment refractory depression. 4 straight days. Well, yeah. So let's see what happened. First of all, the vast majority of patients, and you can see the mean, clearly respond positively. There's no question about that. Please look at that solid black line that tells you what happened at the end of 4 days. Clearly, there's an improvement. But what is very interesting is even though the infusion was stopped after 4 days, and then you follow them for 2 weeks or 4 weeks or 6 weeks or 8 weeks, the patients continue to do well. Not every single one of them, but truly the majority of them. This is a surprising finding, but this is what will really get you, that it wasn't as simple as an antidepressant effect. There was literally a change in how the brain was functioning, the connectivity between these structures that psychologists and psychiatrists and therapists have been interested in, the thinking part of the brain, if you will, the subgenual anterior cingulate cortex, which is part of the limbic system, and the default mode network. That is the part of the brain that ruminates, that thinks about the past, about our past hurts or our worries about the future, the connectivity is decreased. And that's a good thing because this excessive connectivity leads to depression. So do you see ketamine may not just be an antidepressant, it may be an antidepressant, but it may also be a changer of connectivity. And these loosening of the bonds between these excessively talkative brain regions in depression, which is partly mediated by psychedelic experiences, is an important component of how ketamine ultimately exerts its effect. We're not done. Ketamine has something else that's profoundly interesting. It exerts a specific anti-suicide effect in unipolar and bipolar depression, quite specific. In fact, here's a study that shows us even when depression does not improve, even if depression does not improve, what can improve is suicidality, even in very severely ill patients who have had either major depression or bipolar depression. And here they used, again, an infusion of ketamine at 0.5 milligram per kilogram. So yes, we are encountering a medication that was discovered as an anesthetic, but psychiatry has now adopted into its own field that does appear to have effects we are simply not used to seeing in psychiatry. And how interesting this anti-suicide effect can be apparent in 1 hour. How interesting is that? Adolescent major depression. Again, I am certain in your area, you are seeing a sharp rise in adolescent major depression. I'm not at all suggesting that it's first-line therapy. What I am suggesting, though, is that ketamine has now proven its profound value even in adolescent major depression. And you know, there's never any time to waste when you're treating depression, but there's particularly little time to waste when we are treating adolescents. And this study that came out of Yale University not only shows, in comparison to an active comparator, midazolam, that this is effective, it separates from its active comparator in as little as 1 day. This is a very fast-moving effect. And I would say more than half the patients actually have ketamine as a psychedelic response. So my concluding thoughts on ketamine, and we are going to turn our attention to other things in just a second, is ketamine is both medicine and a psychedelic intervention. It appears, like other psychedelics, to really offer a wide plethora of effects. And I encourage you, no matter where you are, please give ketamine a second look, both in terms of addressing mood difficulties, but also its psychedelic effects. And Sandra will talk to you more about, should patients experience such an effect, how to help them integrate that into their betterment. All right, we're now going to turn to psilocybin, and let's do this. Let's now look at, well, what's often called magic mushrooms. But psilocybin is very much now deeply being looked at by multiple researchers, and the National Institute of Health just funded the very first study on psilocybin, actually for smoking cessation, if you can believe it. 2 different organizations are closing in on offering us data, high quality data, FDA quality data, approvable data, to see if it can be effective for major depression. The preliminary evidence looks very positive. One of the organizations is USONA Institute, the other one is Compass, and very soon we should have data from them. But in the meantime, what is the current state of the art in terms of literature on psilocybin? And here we have 2 sessions of psilocybin, just 2. So it's not a chronic use of the medication. And this is what happened compared to a delayed treatment group. You can see that in the blue line. If you look at the orange line, what you're seeing is just 2 treatments, with psilocybin, fairly high dose, 20 milligrams and 30 milligrams. Those are fairly high dose. What you see is at 5 weeks time point and at 8-week time point, that's actually a profound drop in Hamilton and depression scale. So yes, there is something that is happening, but what is happening doesn't appear to be all biologic. It doesn't appear to be that it changes your brain as much as it seems to change the rigid thinking and concrete thinking and negative thinking that our patients with major depression are often stuck in, that perpetuates their depression. I'm certain you have seen that repeatedly in folks, that they can't let go, or they don't know there is any other way to think but the way that they're currently thinking, that the thinking is automatically right. The psychedelic experiences people have during psilocybin treatment can challenge that, can give them alternative ways to look at things. And of course, it's not just the psilocybin experience, it's the pre-work you do, and very definitely the post-work, known as integration, that Sandra will be covering. That's why we don't often think of it as psilocybin therapy. We actually think of it as psilocybin-assisted psychotherapy. In other words, psychotherapy is given the first billing. Psilocybin is much more an agent to facilitate psychotherapy in ways that we've not been able to accomplish without such substances. Does that make sense to you? During Q&A, if you would like for us to, we will definitely clarify it. And by the way, the effect size in the study, please, I hope you're all sitting down, was an astounding 2.5. That's a very highly effective study. Now, that study came to us from Johns Hopkins. This one comes to us from Imperial College in London. This is a very long study. It's an open label study, 6 months long. These are not patients with depression. These are patients with treatment-resistant major depression. Again, 2 doses, 10 milligrams, 7 days later at 25 milligrams. And then let's see how they're doing a week later and 6 months later. So a week later, the effect size in terms of depression improvement, very impressive, 2.2. Please remember, most antidepressants, we use SSRIs, SNRIs, their effect size tends to be 0.6, 0.7. We're talking about 2.2 here. And please remember, they are no longer receiving any medications other than those 2 experiences we talked about. And please keep looking at the persistence of effect. In this particular study, even at 6 months, quite a few, not all, quite a few patients, even though they only had 2 treatments 6 months ago, they are doing well. Here too, I must emphasize, it doesn't appear to be psilocybin. It appears to be psychotherapy assisted with psilocybin. So you really want to think of it, for the first time ever, a true marriage, a true healthy marriage between psychotherapy and pharmacotherapy. So look at the effect sizes. They just really are quite impressive. But you might be saying, I want to see it compared directly to what we use now. Well, okay, fine. Isn't escitalopram, Lexapro, one of the most commonly used medications in all of American medicine, leave alone American psychiatry? How about we compare them head to head? Like, come on, let's see what you got. Well, guess what? Escitalopram and psilocybin have indeed now been compared, and the study is so powerful, the New England Journal of Medicine accepted it for publication just this year. This is from Robin Carhart Harris at Imperial College, who, by the way, has now moved to University of California in San Francisco. So the American explosion of high-quality psychedelic research is well on its way. If I was you, I would definitely get your hands on this article and read it. And during Q&A, if you are interested in actually obtaining a copy of this, just let us know and we will make sure it's available to you. So study is actually a direct one. Double-blind, obviously, placebo-controlled, obviously, and the placebo here is an active comparator. You got SSRI versus psilocybin. It's better than a placebo, active drugs. So What did we see? Well, first of all, let's look at two different things. This is so unusual in our field, right? Let's first look at how depression improved or didn't improve. But let's also make sure we look at wellness improvement. Think about it for a second. Is depression just a disorder of the presence of lots of depressive symptoms? Or is there actually one more problem, which is they also have a deficit in their wellness? Sandra and I coined almost a decade ago a term called wellness deficit disorder. Well, guess what? It's a true one. But here we're going to see if psilocybin offered in conjunction with intense and high quality but limited psychotherapy, does it make a difference? So here is the answer. Number one, on depression, numerically, immediately. In fact, just look at that. Even in 7 days, psilocybin is beating escitalopram. Numerically, it continues to do that continuously. Only at the last study point does it lose statistical significance just a little bit. I see this as a positive study, even though from a statistical perspective, you have to say they did not separate from each other. But boy, had the sample size been just a little bit larger, it sure would have happened. But in terms of wellness, and this is why, folks, Sandra and I are so passionate about psychedelics, it appears to have a profound impact on other traits of human functioning, such as optimism, such as happiness, such as resilience, such as enthusiasm, such as this concept of this totality of wellness. And they used a scale called the Warwick-Edinburgh Wellness Scale. It's a wonderful scale that Sandra and I have had research experience with. Within 14 days, 2 weeks. And again, please remember, these folks only got 2 doses of psilocybin quite a few weeks ago. But check this out, at 2 weeks, do you see the red bar, even with the confidence interval, separate hugely from psilocybin, which is the blue line with the confidence interval bars. And that separation is persistent throughout the study. In other words, can we back up a bit? In other words, there is very good evidence that it can have an antidepressant effect without chronic administration. And on top of that, on wellness, it has a very clear and persistent signal. Now, you might be wondering, okay, fine, can I have some more details? Sure, we looked at the data very closely, and the Carhart-Harris group is reporting not just QIDS SR, patient reported, but also HAM-D, which is clinician reported. Check it out. The average patient who received psilocybin and psychotherapy lost 10 points on their HAM-D at week 6. Average patient on escitalopram who received that plus psychotherapy lost 5 points. That's a pretty significant difference. MADRS, 14 points, 7 points. That's a doubling. It's pretty significant. And then if you look at the side effect burden and the majority of side effects with psilocybin, well, because you don't give it on a daily basis, they dissipate very quickly. They're not persistent. On escitalopram, some of the side effects, obviously, like sexual dysfunction, weight gain, are things that we will have to worry about. Now, this study is not to say that what we are doing currently, which is the use of SSRIs, SNRIs, atypicals, is wrong practice, because it's not. It's just that it's not adequate for a lot of patients, and psychedelic medicine may be one of the royal roads to success for such patients. Now you see why Sandra and I were so excited to talk to you about psychedelic medicine, because it will be very important for us to perhaps utilize it in the right patient once FDA approves such medications, which I hope will happen in the next, I'm guessing, 2 to 3 years. So we're all awaiting results of the final studies from both Compass and USONA. They should be here soon. By the time you and I talk again next year, I promise you, both these organizations will have their data out. Okay, so stay tuned. Finally, I would like to cover MDMA. Most likely, you either encountered it professionally, or most likely you have encountered it in your own college life or in your society, maybe perhaps with your friends. MDMA has literally become a rather important cultural touchstone. But what is the medical evidence for it? And what disorders are we going to look at? And the number one disorder MDMA is being studied in is actually PTSD. And not just simple PTSD, if you will, chronic PTSD with impairment that often has failed to respond to multiple courses of standard psychotherapy, standard pharmacotherapy, and often combination thereof. These are very ill patients. And we now have phase 2 data, and we actually have phase 3 data. I actually think, even though MDMA often is called an empathogen, so it actually increases feelings of connection and forgiveness and understanding, which are at its very core the pathway to success for many of our patients with PTSD. In many patients, if not in most, they also have psychedelic experiences. If your definition of psychedelic is mind manifesting, it often does that. So let's stand back and look at the data. Let's not accept it as the truth just because somebody said so. Let's actually look at the data. So first of all, there are multiple doses, and I like that because more doses means the greater the accuracy of the data. And what we're seeing is 40 milligrams, not that effective, but what we are seeing, 100 milligrams in particular, and to some degree, 125 milligrams has a clear benefit, on the reduction of PTSD symptoms as measured by the gold standard instrument called the CAPS-4. It's based on DSM criteria. And I again want to assure you, these were not simple, straightforward patients. These were recalcitrant, difficult to treat, and really impaired patients. And by the way, the open label data continue to show an improvement. Now you might say, but this is a small study. And you're right, it's a tiny study. Why don't we do this? Let's look at 6 different studies put together. And if you take a look at this photograph, which by the way is a real photo, I didn't take it, but it's a real photo. This is Chicago's shoreline, and you can see there are 6 lightning strikes occurring at the same time. It's a rare event, isn't it? Well, let me show you something. We are encountering another rare event, which is MDMA, 6 different phase 2 studies of MDMA, and we're going to combine the data to see if it's at all effective in PTSD, okay? So it's pooled data from these 6 phase studies, and the results are very convincingly positive. By the way, the control is not placebo, it's just often either 0 dose or 40 milligrams, up to 40 milligrams of MDMA, and the active arm is 75 to 125 milligrams. And I hope you can see, even with the second experimental session, and often with MDMA studies, you do 2 or 3 sessions, okay? 1 is almost never done. You want to cement in the progress because psychotherapy is utilized so intensively. But the upshot of this is MDMA-assisted psychotherapy. And I hope you heard me. I did not say MDMA. I did not say psychotherapy. What I said is MDMA-assisted psychotherapy. That is the combo deal, so to speak, is quite effective with an effect size of 0.8, even in these difficult to treat patients. And it's a persistent effect. Not everyone, but vast majority of patients, once they get better, tend to stay better even without repeat treatment. Now, if repeat treatment is necessary, I think when the drug is approved by the FDA, that will be permissible. Now, here's fireworks, and you're going, why are we looking at fireworks? Well, here's why. Because now we have in the world of psychedelic medicine, the very first modern day phase 3 study with the psychedelic medicine. This is a big deal. This has never happened before. And it just happened this year. And again, this study from MAPS was published in 2021 in a journal no less impressive than Nature Medicine. So, as I said at least a couple of times before, psychedelic medicine is no longer a fringe movement. It is very much at the heart and at the center of psychiatric thinking across the country. Nearly every academic center now has its own psychedelic research and often clinical practice center. There's one at Hopkins, there's one at NYU, there's one at UCSF, there's one at UC Berkeley, which doesn't even have a medical school. But everyone is appreciating that there may be a specific role for it. So the world's first phase 3 study, it's time for you and I to look at it. And Mitchell and colleagues published it. I would again encourage you to read this one. This one is randomized 1-to-1 to receive either the therapy with MDMA or the therapy with placebo. So the placebo patients aren't people who got nothing. They actually got a ton of high quality psychotherapy. So 3 preparatory sessions and 9 integrative therapy sessions. So it's pretty intense. But it's also true that after that intensity is over, then it's not ongoing contact with the medical or the psychotherapy team. And the results are, there they are for you to look at. This is the CAPS. This is the PTSD symptom reduction. And I hope you can see, even after one session, we see a drop in the CAPS score. But after session 2 and after session 3, we see a very significant persistent drop. But you and I also know this, don't we? Our PTSD patients don't just have PTSD symptoms, they also have depressive symptoms. So BDI, which is obviously Beck Depression Inventory, here I hope you're seeing baseline and that being compared to study termination, very significant differences. Even though the placebo arm is not placebo, it's 12 sessions of psychotherapy. But having MDMA as part of the psychotherapy really seems to turbocharge the benefits, both in terms of reduction in PTSD symptomatology, but also reduction in depressive symptoms. And the effect size, 0.91. That's jaw-droppingly impressive. Safety signal, actually mostly reassuring. The safety signal, what little side effects that happened, you can see some of the numbers happened mostly during the treatment with MDMA, the 2 or 3 sessions that they had. Vast majority, no. And in terms of abuse potential, suicidality, QT prolongation, it was a triple no on it. And these were the 3 worries the medical field did have, but it didn't amount to very much. So we should put all of this together, right? So putting it all together, it is becoming very clear that this conversation you and Sandra and I are having is just right. It's happening at just the right time point. We must start preparing our minds and our hearts to examine the data critically. It's not a good idea to run out and embrace every new idea that flies by us. But it's time to start looking at the data critically and be assured the data is of high quality, and be assured the odds are very high. Psychedelic medicine will be part of nearly everyone's practice in one way or another very soon. So let's look into the future of psychedelic research in mental health, shall we? So this is what we can expect. We can expect psychedelic research to show us changes all the way from molecular changes. I just reviewed a paper yesterday on neuroplasticity changes with psychedelics after one treatment. I'm impressed, but I need more. Neurogenesis, synaptogenesis. We're also going to start seeing data on how people literally change how they look at people's sad faces, their negative affect, as you saw me present to you, and improvement in positive affect are things I'm going to start looking at, and this sense of connection. this sense of disconnection that appears to be at epidemic levels in our society, disconnection with ourselves, with our families, with our society, with our neighborhood, with nature. All of these are potentially reversible with psychedelics. And you might say, boy, that's a big ask. But the data actually shows us these are all possibilities. And by the way, we're not done. It's not going to be just depression or PTSD. Substance abuse disorders are well within the sights of psychedelic research. And as I shared with you before, Johns Hopkins became the first institution in America to get federal funding to conduct research with psilocybin in people with nicotine addiction, cigarette addiction. We will look at the data, I'm sure, in time. The future does look quite bright. It does. There's dozens upon dozens of studies currently being conducted. If you get a chance, go to clinicaltrials.gov, type in psychedelics, and be ready for a wonderful, happy surprise. But you do need to be aware that the next generation of psychedelics may not come from nature, may not come from the existing drugs. There are a bunch of designer drugs that are being created and studied, and not in someone's garage, but actually in major laboratories, major pharmaceutical laboratories around the world, because we are wanting cleaner, better, faster, more useful drugs. Of course we do, safer. So as I said, psychedelic medicine is going to be a big part of what you and I do. In the last minute I have with you, I do want to offer you a cautionary tale. And the cautionary tale is, let's guard against excessive and irrational exuberance. You might say, boy, he sounds so excited. And I am, but I also am guarding against being so exuberant that I don't look at any potential negatives. Because look at this. If we don't appreciate that, we may oversell the idea to ourselves and our patients about psychedelic medicine. I wanted to show you that the study that the Imperial College did shows us that quite a few people continue doing well for weeks, months after a psychedelic experience, particularly if they have TRD. But the problem is quite a few patients, particularly if they're severely ill, can relapse. To rephrase it, there is no reason to feel pessimistic about the current ways we treat depression. That, if anything, is going to be augmented by psychedelics, or the other way around. They're not going to be fighting with each other as much as for different patients. Different therapies are necessary. It's also possible in different patients, we may use them sequentially. We may start with one, add another, and flip to the other. All of those are real possibilities. So let's not get overly enthusiastic in such a way that we start disrespecting what we're doing today already. And number two, overly embrace psychedelic medicine. So in summary, just hold tight. Hold tight, because there are a huge number of very well conducted double-blind phase 2, phase 3 studies that are coming our way. And in just a few months, we will have those results. Everything looks incredibly promising right now. But I do think once the data really emerges, we will have a deep understanding of how to embrace, to what degree we should embrace psychedelic medicine. So just hold tight. With that, thank you very much for your attention. Sandra will take over now, and then I'm looking forward to Q&A. Thanks.
Hi, everyone. Let me begin by saying it is so nice to be with all of you. And what an introduction and overview of the data for ketamine, psilocybin, and MDMA. So thank you, Rakesh, for that. So Rakesh told us, this is very enthusiastic. Most clinicians I talk to are so excited about what lies ahead, but we don't want to be too excited. It's important to know that data, but I'm going to spend the rest of our time together today talking about what I think is a really important question, and that is this. As practicing clinicians, as we are waiting for FDA approval, hopefully in the next 2, maybe 3 years. None of us really knows. The question for all of us is this: what do we do when our patients in clinical practice are stepping outside of mainstream treatment and using psychedelics. How do we as clinicians deal with what potentially could be a dilemma? Or I hope after we finish our conversation today and then during Q&A, we can explore maybe it's not a dilemma. Maybe it's an opportunity. And the data that Rakesh presented to all of us will really help us in terms of how we want to answer some of these questions our patients will certainly have. So let's get right to it. So it makes sense. I mean, think about your clinical practice. Our patients are and have and will continue to step outside of mainstream treatment when they don't get better. So think about your patients with treatment-resistant depression, or how about just difficult to treat anxiety? They are going to step outside of that. And just for a little bit of historical context, psychedelics received Schedule I status, illegal, 1970, maybe 1971. And so as I was doing this research, I want you to see, look at this picture. This is what I was reminded of over and over again, Prohibition from the 1920s. And I must ask you, I mean, really, how well did that turn out? And in the course of looking at the literature, I ran across the quote that you see to the left of the screen. Because remember, when psychedelics were scheduled, received Schedule I status, everything went underground. It's not like the practices just stopped because they were at that point deemed illegal. It went underground. And look at this, for every prohibition we create, we also create an underground. So as we think about this, I just want to offer this as one way to look into the world of psychedelics, these three windows. I want you to notice how clinicians view it and how our patients view it really is quite similar. So we either come to this conversation from a place of support, we believe it, we're just waiting for approval. Now with ketamine, obviously we already have that in certain diagnostic categories. So there's that window of support. But look, right next to it is this window of opposition, where some, whether clinicians or patients or lay people, are totally against the use of psychedelics, whether it be for medical use or whether it be for recreational use. So we have this opposition, right? This disagreement. And I would suggest this, that we add an additional window to both perspectives of clinicians as well as patients. And that is one of curiosity. Because let's think about it. We come to this table, this conversation about psychedelics based on our own personal histories, how we were trained. Do we live and work in a conservative or liberal setting? Right? So if we are aware of what we bring to this conversation, we may be able to make more space, if you will, for this sense of curiosity, leaning into the other side to better understand what, why, and how they're sort of interacting in the psychedelic space. So this is what we can expect. Our patients are going to come to see us, and this is what's going to happen. There are going to be questions after questions. I want you to know my patient practice, psychotherapy practice, my patients are very well informed. They ask very inquisitive, informed questions. So for us as practitioners to really engage in that conversation, we need to know the data, but we also want to be really aware of what our biases may be and what we bring to this table of conversation. Now, look, I titled this The Dilemma That We May Face as Clinicians, but I'm going to change it. And let's think about what is the opportunity for us in terms of this conversation, right? So we already have a therapeutic alliance, if you will, established with our patients. But what may happen is a question like this. I'm interested in taking a psychedelic substance. I've read all the studies. Can you give me a psychedelic substance or help me find some? Now, this clinician takes a very clear, boundary-driven response, saying, no, I can't help you with this. What you're asking for is illegal. As a therapist, my number one concern is being mindful of the risks for both of us. I will say this may fit very well with how you like to work. Others may take a softer, less direct approach. But I will tell you this, no matter how we engage in the conversation, this is what I would suggest, that we simply be prepared. Don't wait for the questions to be asked. Consider the questions, and that's what we're going to do in our time together today, is think about some of the things that our patients may bring to us and how we can best be informed to be able to have a really productive conversation with our patients. So here we go. Think about this. I love Walt Whitman's quote, be curious, not judgmental. Remember our windows into psychedelics, that third window of curiosity. Because when we're aware of what we bring from our history, what our beliefs are, we're curious about what our patients bring to the table, we're just in a much better place, if you will, to listen, to learn from the other person, and then to really grow in terms of options and resources. I love this. Looking again, as I began to build this slide deck, Albert Einstein made me think, is curiosity medicine? Because look what he told people. I have no special talent. Really? Again, I have no special talent. I am only passionately curious. So if curiosity is medicine in the space of psychedelics, if we as clinicians lean in with just radical curiosity, I can't help but wonder what might happen. But here is the best advice I can give all of us today. Caution at this point is the rule. We want to, as practitioners, really think about how we want to handle these conversations long before they happen. And remember, based on what Rakesh told us, other than ketamine, these substances are still Schedule 1 and illegal. Now, let me pull these up. You guys can take a look at these. But I want, as we have this conversation today, we really want to think about, what do we as clinicians, what do we have at hand, our resources to share with our patients at this point, while we're kind of still waiting to see what the next 2 to 3 years brings in terms of FDA approval. And I will tell you this, Rakesh and I over the last 3 years have been collecting data. It's an online anonymous survey. I'll tell you about it a bit more in just a second. But we were so curious, as Rakesh mentioned earlier, about this relationship between psychedelics and wellness. And you'll see in the reference on this slide, you can actually, if you're interested and willing, go online, complete the online anonymous survey. You can find that at psychedelicsandwellness.com. So in the course of 3 years, I can tell you this, the findings are quite remarkably positive, but the need is great. And honestly, my friends, that seems to be a bit of an understatement, because throughout the 3 years, we've had so many emails, phone calls from people who have completed the survey and having shared their personal stories of tragedy. Just to give you a flavor of that, you can see the first example, a veteran, multiple IED blast, best friend shot in the head, standing next to this person, many years, no treatment at all. And then look in the world of our classic patients that we take care of, depression, anxiety, PTSD, different meds over the course of 10 years, still not able to find something that works. Another person tried all medications, desperately need help. So as we as clinicians, as we're waiting to see what FDA does with regards to Mdma and psilocybin, ketamine is different, but as we wait, we have to weigh the risk that we're willing to take. I'll talk with you about that some in just a moment. But I want you to be aware of what resources we do have as clinicians. What can we offer our patients that falls on the side, if you will, of legal use of psychedelics at this point? First option, join a clinical trial. And I want you just for a moment, let your eyes kind of look across this slide. And I just want you to be aware that many people, organizations, academic settings, corporations, they really have paved the way for giving us access to an evidence-based data set looking at psychedelics in treatment of mental health conditions. There are many more than this across the world. But I want you to consider this. Long before the advent of clinical trials, psychedelics have been used by humans in their ritual ceremonies. In fact, archaeologists have fossil evidence showing that fact, that more than 10,000 years ago, humans were using psychedelics in ritual ceremonies. Now, I apologize, I just could not get this image kind of documenting the historical background of psychedelics where it's clear and readable. I would strongly suggest go to the reference and look at that on your computer. They're absolutely beautiful illustrations. And you can see, I've just sort of highlighted for you some of the documentation throughout the span of history. Now, here's another very interesting theory. I'll say this, I would encourage you, if you're not familiar with the stoned ape theory, go look it up, read about it. It's a theory that was presented by Terence McKenna, a renowned mystic and psychonaut. And here it is, just sort of in a nutshell. He proposed that the evolutionary leap between Homo erectus and Homo sapiens, get this, was a dietary addition. Interestingly, that dietary addition, according to Terence McKenna, was psilocybin cubensis, or what we often refer to as magic mushrooms. So a very interesting theory. Take a look and then you decide. So as clinicians, if our patients come to us and they're not really aware of what's happening around the globe, I think it behooves us. It is a responsibility for us to know so that we can help appropriately educate and inform our patients. And this is just a sampling. You can see Rakesh talked to us about the clinical trials, the first phase 3 from MAPS. Clinicaltrials.gov, he also mentioned that this is one of the greatest resources for our patients to be able to see which psychedelic trials have been registered, and this is the go-to site. Academic settings as well. You can see to the right of the screen, European research hubs, many of them listed there. You see Compass Pathways, also Imperial College of London. Rakesh shared some of their data just a bit ago. So again, if we want to help our patients be able to survey the landscape, here's another option. Simply go to psychedelic.support, and they have a really nicely done clinical trials database where a person can research the substance, the condition that it's being researched for, and then also the status of that clinical trial. I love this site because it visually is so interesting. We can really look at what's happening around the world based on, again, the substance and the condition that's being treated. If you go to the site, you click on any of these buttons where there's actual research happening, it will give you all the details. All right, psychedelic integration. Rakesh referenced this before, and I want to say this could be an entire full presentation just talking about the importance of psychedelic integration. So those are the sessions. Rakesh talked about the Mdma phase 3, 3 preparatory sessions, then the medicine sessions, and then in that study, there were 9 integration therapy sessions. And I will say this is where the work really is cemented. This is where the meaning making happens in the integration sessions post the medicine experience. And you can see just a basic definition of integration, but I brought this animation to this presentation just to point out that many times during these experiences, if you think about this in terms of puzzle pieces, there will be different pieces of the puzzle that will appear. And oftentimes, those in the journey don't really understand what those individual puzzle pieces mean. And so the integration work allows for that exploration to really begin to take those pieces and begin to create a narrative and create meaning making around the experience. A quote, I just want to share this with you because this is about honoring the experience of the medicine session. What are we going to do with those learnings? And this group says that entheogenic integration refers to the process by which the material that's accessed and insights gained in the entheogenic experience are incorporated over time into one's life in a way that benefits not only the individual, but also their community. Another quote, just to drive home this point, from Alan Watts, a British speaker and writer. He's really credited with being the first person to take Eastern wisdom and translate it for Westerners. And this is what he tells us. Strictly speaking, these drugs do not impart wisdom at all, any more than the microscope alone gives knowledge. They provide the raw materials of wisdom, and they are useful to the extent that the individual can integrate what they reveal into the whole pattern of behavior and the whole system of knowledge. Just love that description of psychedelic integration work. Speaking of that, patients are going to be asking us as their clinicians, how do I find somebody like that? And I want you to know this is not an exhaustive list. I just pulled 3 that I'm very familiar with. These 3 organizations, we already talked about psychedelic.support, but also MAPS, and then the Ketamine Research Institute, the CREA Institute, they all on their websites have psychedelic integration provider lists. So wonderful resources to be able to share with our patients. Okay, harm reduction. We cannot have this conversation without exploring harm reduction to some degree. And just, again, a definition, harm reduction is all about reducing negative consequences that are associated with drug use. But also to remember, it's also a movement for social justice. And that's built on a belief in and a respect for really the rights of people who use drugs. And it's not a new term. I mean, take a look. It was coined in 1980, but look at that second bullet point. There are writings, medical writings, as far back as 1926 from the UK speaking about the actual process and the importance of harm reduction. And I think the best way to really understand harm reduction is to talk about what it is not. And it is not zero tolerance. It is completely in contrast to the war on drugs and just say no. It is not an abstinence-only approach like these. Now, this is only one person's opinion, a journalist. And you may, as I read it to you, you may stop and think, do I agree with that? Maybe, maybe not, but I think it's worth considering. So here's what this person says. The US government must stand down and loosen these legal barriers to research and treatment with psychedelics, or else it indirectly harms thousands of patients, both in the US and across the world each year. Very definitive on their position. As I considered this question, do I agree with it or not? I ran across this quote. And this is what I want to bring your attention to. Know where you stand knowingly. So remember our windows into the world of psychedelics. Know where you stand. In full support, partial support, full opposition, partial opposition. Where do you stand on this idea of curiosity as medicine? What are the biases, the experiences? What is your context? What are the variables that influence your particular window? And I do believe this, that if we come to this table of conversation around psychedelics with that in mind, what is it that we bring to the table? Good things will come. Now, speaking about harm reduction, I must share these resources with you. Dance Safe, the Zendo Project, Arrowwood, and the Fireside Project. I'm sure that many of you are familiar with these, but if not, I just want you to have kind of a go-to place where you can then begin some of your own exploration and learning so you can share these with your patients. Fireside Project is probably the newest of all of these, but it's quite remarkable. So it's like, it is a hotline where people can call in two different scenarios. One, they're having a psychedelic experience. They are in a psychedelic experience and it has become quite difficult for them and they need immediate support. Or it could also be for someone who has completed a psychedelic experience, but they need assistance with integrating and making sense, meaning making of that experience. So Fireside Project, an amazing service that we want our patients to know about. Zendo Project, one of the projects that's come out of MAPS. And I just want you to see some of their 4 principles. Create a safe space. This is about sitting with the person, not guiding. It is talking through, not down. Remember the thing from Walt Whitman earlier about curiosity and not judgment. And remember, difficult is not the same as bad. Oftentimes we will hear patients talk about bad experiences. And again, this is an opportunity for that curiosity to lean in and to offer education, that sometimes some of the greatest opportunities for integration work come from difficult experiences. So tips for us as clinicians as we begin to think about this. 1, know the law in your state. And our job, I really believe, is to assist our patients in this risk-benefit analysis, helping them to make their own informed choices. Us as clinicians, consult with an attorney, know what's happening in your state, know what position your licensing board takes on psychedelics. Currently, definitely in the space of ketamine, the use of ketamine currently, know where your licensing board stands, as well as your professional liability insurance carrier. Know the context. We talked about this earlier. Do you live and practice in a conservative or liberal setting? And then last but not least, I think this is so important. We as clinicians must make the best decision. And the question is this: how much risk are we willing to take? And that question really will help guide us. Now, the last one, it's a little bit hard to see because of the reference. This talks about during this entire process, don't practice in isolation. It's the same advice we give for any of us as clinicians. Find mentors, find supervision, be prepared, be well educated around the topic of psychedelics. Okay, option 4. Legal psychedelics. Ketamine, Rakesh has already done a great job introducing us to the data in the world of ketamine, but we'll look at just one slide, but psychedelic tourism as well as churches using psychedelics as a sacrament within their church. Now, this one, I'll just let you take a quick look. Rakesh has really covered all of this, but I will say, look at that first top of the slide, the 3rd bullet point, and remember, ketamine, no matter the route of administration, can produce mystical experiences. It can also be a heart-opening, a heart-expanding experience. There never are sort of black or white around any of these psychedelic substances. Many times it is, if not all times, based individually on the patient, and their expectations about the experience really does influence the actual experience itself. That's why the preparation prior to a psychedelic experience is absolutely critical. All right, I want you to simply think about this as your resource. Know the landscape around ketamine-assisted psychotherapy. It's referred to as CAP. And I've listed for you 8 or so different organizations, groups that are offering top-notch ketamine-assisted psychotherapy programs. Now, during COVID, those were obviously all online, but in the last, I would say, month, maybe 2 months, some of these groups are now offering in-person with an experiential component programs for their students. And also during Q&A, if you want to talk about that in greater detail, I think that would be the perfect time. All right, please know that patients, if yours are anything like mine, and I'm sure they are, they're going to be interested in psychedelic tourism because it's possible to go outside of the United States and legally participate in psychedelic retreats. And look, we want to help our patients. That's one of the reasons that we move into the space of mental health. We have this true internal heart drive to help other human beings. And so in this situation, it is quite a tug. You may have experienced it yourself, but for me, I certainly have, where patients are desperate because mainstream psychiatry is not meeting their needs. They're not better, or they get better, but it just doesn't last. And this can go on for decades, as you all well know. So when they come to us and they say things like, hey, I heard about a retreat center, blah, blah, blah. Do you know about it? Would you recommend it? Do you think that this is a good idea for me and my treatment? All reasonable questions for our patients to ask us. Remember, be prepared. Know what level of risk you're willing to take. This kind of shows in a silly way, we want to tread lightly. We want to proceed with caution. Because think about this as a possibility. Our patients come to us, they ask those questions, and we say, yeah, you know, that one that you asked about, I do know a little bit about it. I would say thumbs up, it's a good idea. And then it doesn't go well for whatever reason. We must think about what is our liability for giving the rubber stamp of approval to that form of treatment when it is not legal in the United States. So when we think about some of the risks associated with psychedelic retreats, we'll just highlight a couple of them. We do not know the potency and purity of the medicine like you would know in a clinical trial setting. If you've read about the retreat centers, you've kept an eye on these programs, there is and has been documented cases of sexual assault. They are quite expensive, cost, accessibility. Some of them can be quite expensive. We have to keep in mind the next 2 bullet points: reciprocity with the indigenous communities. What about sustainability issues? And then what we just talked about, our liability regarding illegal substances. That last bullet point, let's not overlook that there are many retreat centers. So that our patients can make an informed decision, we want to just encourage them to know what is the protocol, what are the credentials of the people running these retreat centers, what are their training protocols. Now, this one I only share with you, you may be aware of it, Retreat Guru. All I want you to know is this: it's very similar to kayak. If a patient is planning to go to a psychedelic retreat center, they can go to this website and they can research it in a similar way. If you were planning a trip to Hawaii and you wanted to know the best activities, the best hotel, the best place to eat, well, Retreat Guru has created exactly that kind of a platform for psychedelic tourism. And I mentioned this earlier. Another legal path is church membership. And in the United States, there are 3 different churches recognized. You'll see them here. And they are considered legally as bona fide religious institutions. And what separates them or distinguishes them and makes them important to us in the conversation of psychedelics is this: that their religious sacrament are psychedelics. Patients will come to you, they will know about these, they will be asking you questions. So you can research this, you can Google it, use this slide to dig into each one of them to understand better how this is set up, how it is considered legal within the United States, and what that experience might be like for one of our patients if they decide to go that route. And then our final fifth option, please know this, that there are other paths to non-ordinary states of consciousness besides psychedelic medicines. And here they are. Here's two. I mean, there are others. Breath work as well as meditation. So I would encourage you, look into each of these in terms of their ability to access non-ordinary states of consciousness. And this is just another way for us to provide education to our patients because they may not know about these two paths. And the way I love to think about that, this is the title of this slide, All Roads Lead to Rome, that we can access that non-ordinary state of consciousness many different ways. So I will end by just saying this. We as practicing clinicians, other than ketamine, we're in a little bit of a holding pattern, waiting to see what the FDA does. And so we're also in a unique position of opportunity, of education, to really engage with our patients in conversations about psychedelics to help them make the best possible decision they can. So thank you so much for your time and attention. And Rakesh and I will be joining you shortly for Q&A, and we're really looking forward to it.
Well, Sandra, that was wonderful. Thank you so much. I'm going to let Cliff ask a few questions while I send something back channel to Rakesh, okay?
Sounds good. Thank you, Ben. Hi, Cliff, and hello to everyone. It's nice to be with you this afternoon.
Thank you so much for the excellent presentation. Let me get two things out of the way real quick because this is easy. There were two requests for access to the study from the Imperial College in England that Rakesh did. And I'm pretty sure the reference is on the slide because I wouldn't have approved his slide set for CME unless there was a reference on the slide. And so I think we need to, at some point, remind our attendees that how they can download the slides from each of the presenters. So I'll just put that out there and then we'll get back to that at another time.
Perfect.
Okay. Here's a good one. Is it likely, and this is just a guess, is it likely that ketamine may replace urgent inpatient care or mobile crisis interventions of various kinds in the near future?
It's a thought-provoking question, but it's a very difficult one to answer because I just simply think we do not know what's going to happen moving forward. The data that Rakesh shared on ketamine in terms of immediacy of effect within one day. So that would lead me to think, okay, this may be in crisis situations a good idea, something for us to consider. But I'll also bring to the table, maybe just within the last 2 years, the young gentleman, it wasn't in Denver proper, but it was somewhere, maybe Aurora, Colorado, where someone had called in about a young man walking down the street. The police came, and either with or maybe with EMS help, they gave him a very large dose of ketamine and the young man died. And so now there's new laws, a lot of things changed in response to that action. So even if this were to go forward as a possibility, ketamine to be used in that situation, I think these previous cases are going to be called to the table for conversation because the protocol would have to be very specific in terms of how we were to use it in those situations. But I think it's a possibility. It's an interesting one.
Good. Here's another one on that's already been answered by you.
Oh, okay.
But I'll ask it and see if you have anything else to say about it. Is ketamine also one of the psychedelics that can be considered a psychotherapy assisted treatment? And you said yes, it can, and you explained that.
Yes, yes, and it's quite powerful. And, you know, some of the pushback on that, Cliff, is this, that when ketamine clinics began appearing over the last several years, that there's a lot of pushback about that the IV infusion clinics don't offer the ketamine assisted, the psychotherapy, sort of the marriage of the medicine and the therapy together. And I mean, there's a lot to be learned from that. We're learning as we go, but the ketamine assisted psychotherapy programs are blossoming. There are many to choose from, as you saw from the one slide I shared. If you are working in a ketamine clinic and you do not have that training or know about it, find one of these online training programs, because the best way I can describe it, it is a missed opportunity not to sort of marry ketamine with the psychotherapy specific to that medicine.
Thanks. This next question is from someone who really needs to know this answer, but the answer would vary from location to location. Is ketamine ever administered by advanced practice nurses without physician supervision? And I think that would vary from place to place, what's available.
You know, there are so many questions. I'm on a member of a ketamine listserv that has about 400 providers from a variety of specialties. I'd group them into two, prescribers and non-prescribers. And one of the psychedelic assisted psychotherapies resources I shared was the CREA Research Institute. And the woman who runs that is a psychologist, Raquel Bennett, and she is a leader in this space. And questions regarding legality, guidelines for the use of ketamine, please visit her website, because her guidelines are really, they've been used in a number of court cases. She's just remarkably skilled and knowledgeable in this area. And Cliff, to your point, it is state to state. And so it really is a question of checking with an attorney for what your state laws are, but also your licensing board and your insurance carrier. They sometimes don't all agree. They're not all, they're not in alignment. So it's a little bit of extra work on our part to really know what the boundaries are, but it's well worth checking it out before you jump in.
Here's an interesting one. They're all interesting. And there's a little bit of phrasing beforehand that I'll just go ahead and add here. The responsible use of entheogens by indigenous peoples has always used a spiritual guide for personal growth and not for partying or microdosing or other forms of recreation. And so the question then is the illicit use of psilocybin more likely to be self-medicating, since that's in the news now, or just euphoria seeking or some recreational use? Or is that known?
I don't think it's known. I think it is a combination of all of the above, right? I think that that's probably our best answer. I will tell you this, just to give you kind of an idea of what preferred psychedelics people are reporting. I don't think it specifically answers the question, but it does offer some insight. Rakesh and I in 2019 launched an online anonymous survey. And if people are interested in completing it, we're still collecting data. You can go to psychedelicsandwellness.com. It's about an 8 to 10 minute online anonymous survey looking at the intersection between psychedelics and wellness. So we did pre-post with PHQ-9, GAD-7, and the Hero Wellness Scale. We to date have we have more than 3,000 completed surveys, which far exceeds anything we ever expected when we first launched the survey. But when you look at, we asked people who completed the survey what their preferred psychedelic of choice was, and top two, without a doubt, LSD and magic mushrooms. Now, there was a sampling of everything else, smaller, because we gave other options, peyote, mescaline, synthetic, different psychedelics, and LSD and magic mushrooms accounted for about 2/3 of all responses. So within that, I'm guessing that there's going to be recreational, there's going to be microdosing, and there's also going to be self-treatment. But here's another one. What about just the betterment of well? Right? That could be microdosing, but it could also be people who do not come to the world of psychedelics with any psychiatric difficulty. They come to that world and that experience, for now underground, looking for betterment of well. Bob Jesse, who was a luminary in the psychedelic space, he was part of the early meetings at Esalen in Big Sur along the coast, beautiful Highway 1 in California. I think that was the late 50s, early 60s. And he's credited with talking about psychedelics being used for the betterment of well people. So, yeah, it's an interesting way to think about all of this.
This is kind of a throwback, a tie between Dr. Rakesh and yourself, and that would be, what do we know about any data on the use of psychedelics in bipolar disorder?
Yeah, so this is going to be a combination of what people in underground work will tell you and what happens in clinical trials, right? And so in clinical trials, for any study that I've looked at, bipolar, I've not ever seen a clinical trial where bipolar is an inclusion. It's always an exclusion, just like history of psychosis, diagnosis of schizophrenia. And some of the clinical trials even go so far as to say those presentations in a first-degree family member, right? And so, I mean, really, we all understand why they're doing that, to protect patients. But when you transition from clinical trials into real patients in the real world, how many times do we see that? I mean, how many of our patients actually come to treatment with those difficulties? Probably more times than not. So it's a little bit of a challenge, but those are usually exclusions in clinical trials.
Do you think that this question is, do you think, of course, who knows, do you think that the cost of psychedelics, once they become legal, well, like ketamine, is it possible that the cost would decrease as these drugs move through more research? That was the first question. FDA approvals, the second question, or a change in state and federal laws is the third question. Would the cost diminish so they could be more available for people?
Yeah. So one of the biggest points of contention in most things we read about psychedelics in a medicalized setting is that they will be so expensive because of the psychotherapy component. So when you think about a psilocybin medicine journey, 5 to 7 hours, something like that, LSD even longer, and you have 2 clinicians present, not only for that whole medicine experience, but for the preparation work and then the integration work, you can see the cost becomes really an issue of privilege. And so in our world now, that is a hot topic. And so accessibility is really being discussed. And my best answer is this: I don't know exactly, but based on history, I'm a type 1 diabetic. I've been diabetic for this year 2022 will be 34 years. When I was first diagnosed, a glucose blood machine was the size. Now, you may have very young people in your audience, so they won't get my reference, but it was the size of like an 8-track tape, right? Like a video thing. They were huge and they cost several $1,000s. Now you can go into Walmart, Target, online, and you pay maybe $20. So the cost has gone down with time. So I cannot imagine that in the world of psychedelics, we wouldn't see the same thing. But I also think that the community that is pushing for access and really being fair, that this should be available to everyone, is going to push that cause forward. So I think it'll be a combination of time. Everything is less in cost with time when it comes to medical devices or medicine, we hope. So I'm hopeful that will happen, but I know that when these first come out, I think what we'll do is we'll rely on nonprofits, people who have had life-changing, transformative experiences, who start 501(c)(3)s to raise money to allow underserved, underprivileged people from their own community, like veterans, to have access to this treatment. So in some ways, we're going to have to rely on the goodwill and open-heartedness of people to help those who are less advantaged.
Thank you so much. Ben, can you
Yeah,
help us with, can you help us with the question about how to access slides? And
Yes.
there were also two questions that were directly targeted for Dr. Rakesh, so we'll send those to him some other time.
Right, I did send those to his cell phone. The question on slides, at the top of the conference website, there is a tab that says slides. And if you click on that, you can scroll down to today's sessions and you have access to the slides for today's sessions. All you have to do is click on this session and open it up, and then you can print yourself a copy. So Sandra, I did have a question for you. And I first of all, I want to thank you for dropping this line into your presentation about opportunities for therapists. And I pounced on that phrase because I've seen lots of material published in recent months about what I call opportunities for the field with regards to use of these medications with depression or PTSD or anxiety, that sort of thing. And I wish you would just kind of wrap up with your thoughts on other opportunities here.
Oh, sure. If I may also, Ben, just offer this. If you look at the reference for that particular article that Rakesh referenced, if you don't have academic access to an academic library, and I'm not sure if it's available open access, I'm not certain about that, but if you want it, feel free to email me. Let me just give you the email address. It's Dr. Jane, DRJAIN, at wild5wellness.com. And the 5 is the number 5, not spelled out. And I'll be happy to send you a PDF of that study.
Great. Thank you.
Great question, Ben, about opportunity. I think that I didn't want that the conversation around psychedelics with our patients to just be framed as a dilemma, but it is an opportunity to really provide our patients with access to what's available, what almost to do their own risk benefit before they make their own decisions. And how involved we are, how directive we are, absolutely depends upon how much risk at this point we are willing to shoulder ourselves. Now, your question, I think, may be a little bit different in terms of what are the opportunities. The most common question I get is this. Do you believe that it's a good idea to do a psychedelic assisted psychotherapy training program? Because most of them start at about $10,000 plus travel. Now, that's pre-COVID, so a lot of it's online now, but it's still a hefty chunk of money. Because what we don't know is this. Number one, is FDA going to approve MDMA and psilocybin? We don't know. And secondly, is the FDA going to actually say which training program is the one that's required? So what happens if you choose one that's not the one, right? So I always answer this way. Do it if you're led to do it for self-enrichment. And if that opportunity presents itself, you'll be well prepared, right? So not a very definitive answer, but I do believe these medicines are going to get FDA approval. I'm hopeful, but pretty confident too, because the data is so good. And I think that it is going to open up just a wonderful list of opportunities for all of us as practitioners to expand our practices, to collaborate with other providers, and really kind of change the field in terms of how we practice. So I'm really looking forward to what lies ahead.
Great. Thank you, Sandra, and thank you, Rakesh. We greatly appreciate y'all. This was a fantastic session and very, very interesting.